What's up, Ninja Nerds? In this video today, we're going to be talking about hypothyroidism. But before we get started, please continue to support us by hitting that like button, commenting down in the comment section, and please subscribe. Also, down in the description box, you guys can click on the descriptions to our social media platforms like Facebook and Instagram. Also, we'll have a link to our Patreon. On our Patreon, we have comprehensive notes on this topic, as well as hand-drawn diagrams by Kristen before and after it's been filmed. So go check that out to aid in your learning experience. All right, Ninja Nerds, let's get into it. All right, Ninja Nerds, so before we start talking about hypothyroidism itself, we have to take a quick little dive into the physiology of the thyroid hormone and the hypothalamic pituitary thyroid axis. I know it sounds like a lot. It's really simple, and we're going to do a quick little breeze through it because I want us to focus more on the disease than the physiology. So the first thing I need us to take a look at here is the anatomical structure here of our hypothalamus and pituitary. So up here is our hypothalamus, right? It's our master endocrine regulator. And what it does is there's nuclei in here that release a particular type of hormone called thyrotropin releasing hormone, also known as TRH. TRH, then when released by the hypothalamus, moves down via the hypophyseal portal system into the anterior pituitary. In the anterior pituitary, there's cells called thyrotropes that are stimulated by TRH. And again, once these cells in the anterior pituitary are stimulated by TRH, it triggers them to release another hormone called TSH, also known as thyroid stimulating hormone. The thyroid stimulating hormone that's made by the anterior pituitary then goes to the thyroid gland itself. And if we look at it at the cellular level, it actually binds onto receptors on follicular cells. But the overall effect, the generalized effect, is once it stimulates the thyroid gland, it tells the thyroid gland to make two particular hormones, but the collective combination of them is thyroid hormone, and that is T4 and T3. The majority of this combo of thyroid hormone that's made, 90% of it is T4, and only the remaining 10% of it is T3 that's made by the thyroid gland. But the combo is thyroid hormone. Now, let's zoom in on the follicular cell and actually kind of see the mechanism because it's pertinent to the pathophys. So if we take a look, zoom in on a follicular cell here, and here we have it. Here we're going to have that thyroid stimulating hormone. And what it does is it binds onto a TSH receptor. You see that blue little protein there? It binds onto a G protein coupled receptor. We're not going to go through this path, but we Ninja Nerds, we know it already. What would it do? It increases cyclic AMP, increases protein kinase A, and protein kinase A phosphorylates transcription factors that stimulate genes. And these genes, once activated, will transcribe and translate particular proteins. And you know what that protein is that is made with response to TSH production? It is thyroglobulin. It's a very important protein that is needed for thyroid hormone synthesis. So that's one effect of the TSH, is stimulating thyroglobulin synthesis. The second effect is it increases cyclic AMP, increases protein kinase A, and phosphorylates another particular protein, which is a very integral enzyme here. And this is called, we're going to abbreviate it, thyroid peroxidase, TPO, very important one here. Now, what does TPO do? In order for us to understand its effect, we have to talk about one quick thing here. You know these follicular cells? They really depend upon iodine. They need iodine in order to function. And so what happens is, in our blood, we have a nice, beautiful concentration of iodide. And what happens is we bring the iodide into the follicular cells via what's called sodium iodide symporters. And once we bring this iodide here, we use this enzyme called TPO. It's really interesting. All it does is it removes the electrons from iodide and converts it into iodine. So that's the first thing the thyroid peroxidase does. The second thing it does is the thyroid peroxidase takes iodine and thyroglobulin and stimulates the fusion of these two. And by the result of that, what do we get? We get what's called iodinated thyroglobulin. Not super complex, right? But here's what's interesting. Within the structure of iodinated thyroglobulin is T4 and T3, thyroid hormone. It's within this structure. So what we need to do is we need to cleave the T3 and T4 out of it. How do we do that? We need proteolytic enzymes. Where are they? In the cell. Take the iodinated thyroglobulin, bring it back into this follicular cell. After we bring it back into the follicular cell, we utilize proteolytic enzymes that cleave out of the iodinated thyroglobulin what hormones? T3 and T4. That's where we get that T3 and T4 from the thyroid gland. Now, really quickly, so you guys understand where is all of this stuff happening, I just want to give you a quick little diagram. When you look at a thyroid follicle, your follicular cells are making this edge, like a little kind of circle, if you will. And here's all the follicular cells. So we're just zooming. Let's say that we're zooming in on just that follicular cell. That follicular cell was stimulated by the TSH and it was producing all of that thyroglobulin here in the center. So when I'm saying all of this thyroglobulin iodination process where it's occurring inside of the central portion of the follicle. And then some of that thyroglobulin will get taken back up into the cells. And then what will we do with it? Make T3 and T4. So I just want you guys to understand a little bit about the anatomy of that first, okay? Okay, so we've made thyroid hormone. Now that we've made it, how does it exert its metabolic effect? I don't want us to go too crazy here, but what happens is T4, let's say we take any cell, any nucleated cell, okay, that is capable of performing metabolism, okay, any kind of metabolic function. What it does is it primarily takes up T4. Once T4 is inside of our metabolic cells, there's an enzyme called deiodinases which convert T4 into T3. What I need you guys to remember is T3 is the active form of thyroid hormone. This is the one that can exert its effect. So then what happens is T3 binds onto intracellular receptors, activates genes, and increases the expression of proteins. You know what kind of proteins it makes? There's tons of proteins that it makes, but one that I really want you to know is these sodium-potassium ATPases. These are the big ones I really don't want you to forget about. And here's why. What do these do? I'm not really worried about that. What I want you guys to know is that every time these pumps are working, they use ATP, and they use a lot of it. And if I increase the expression of these sodium-potassium ATPases, I use more ATP. If I use more ATP, that means I need to generate more ATP. How do we generate ATP in the body? We break down food molecules to generate ATP. What are the processes that thyroid hormone needs to generate to help make ATP? The big one here is glycogenolysis, which is breaking down glycogen into glucose and then sending it through the glycolytic pathway. With that being said, it also will stimulate glycolysis, which is breaking down glucose into pyruvate and acetyl-CoA, and then again making ATP. And the real big one that you need to know is it also helps to stimulate lipolysis, breaking down lipids into fatty acids and glycerol. All of these things generate ATP, but increase your metabolism within all of your cells. Okay, so the next thing is talking about how thyroid hormone affects other target organs other than just nucleated cells. The big thing I really want you to remember is the heart. And it does a couple things to the heart. One of the big things is that it kind of helps to increase beta adrenergic, so beta adrenergic receptor sensitivity. And all that means is that if I have my sensitivity of those beta adrenergic receptors increased, every time epinephrine, norepinephrine bind to them, their effects are a little bit more amplified. And the effects that you primarily see with that is that you see an increase in heart rate, a chronotropic action, and an increase in contractility, and that is a inotropic action. There's one more thing though that we really need to mention, and that it also, thyroid hormone, its levels maintains vasomotor tone. What does that mean? It means it kind of has a nice balance between vasoconstriction and vasodilation. So the next thing I want you to remember is that it maintains vasomotor tone. Very, very important one I need you to know here. The next thing acts on the bones, and it maintains a beautiful balance between osteoclasts, so maintains a balance between osteoclasts and osteoblasts. That's a big one. Okay, maintains osteoblasts and osteoclasts. Okay, and again, osteoblasts deposit bone, or deposit calcium into the bone. Osteoclasts pull calcium from the bone. There's another big thing that you need to know, and that is that it helps to control the development of our skeletal system and the maturation of our skeletal system. So it plays a role within bone development as well as bone maturation. Okay? Very important. It also helps with our central nervous system, right? So it helps particularly within the nervous system to do what? Increase your sympathetic nervous system activity, okay? Within the GI tract, it helps to do what? Helps to increase the GI motility. And it helps to increase the GI secretions. Within the skin, it maintains beautiful blood flow through the skin. So that's another important one, is that it helps to increase blood flow to the skin. If you increase blood flow to the skin, remember, skin is actually your epidermis, but it's also your hair. Your hair is actually skin cells. Your nails are skin cells. So it's important for the growth of hair, skin, and nails. Good blood flow, lots of oxygen, lots of nutrients to those tissues. So increased blood flow is important for growth of what structures? Hair, skin, nails. It's also important because not just a lot of blood flow, but also there's thyroid hormone regulates the activity of your sebaceous glands and your sweat glands. So it also helps to increase sebum and sweat production. So that's also important. Beautiful. The next thing is your reproductive system. It's important not just for helping to develop the reproductive system, but also maintenance of the reproductive system. So it helps in the role of development of repro, but also just your general function from day to day. Another thing is we'll talk about is it also can control a particular type of hormone called sex hormone, or protein called sex hormone binding globulin. It regulates the levels of this, which is important for carrying particular types of steroid hormones like estrogen and progesterone. And there's one other thing. TRH, which we'll talk about a little bit, it's related to thyroid hormone, also can affect, and we'll talk about this very heavily, LH and FSH. That's very important, okay, which control estrogen and testosterone, progesterone production. So remember, development and function of repro, sex hormone binding globulin control, and that TRH, which is related to thyroid hormone, also can affect LSH and FSH. All right, beautiful. The next thing is your fibroblasts. It controls your fibroblasts, and how it does this is your fibroblasts make a particular molecule called glycosaminoglycans. And what thyroid hormone does is it controls the production of glycosaminoglycans and the degradation of glycosaminoglycans, okay? So it helps to maintain the glycosaminoglycan production and degradation. Very important. The next thing, and the last type of physiological activity, is within our muscle cells. It plays a role within the development. It plays a role within the regeneration of our skeletal muscle cells. It also plays a role in muscle contraction. And the way it does this is very interesting. It controls muscle contraction by regulating the activity of those calcium ATPases that are present on the sarcoplasmic reticulum. If we control those, that controls the amount of calcium that's in the muscle, that regulates our muscle contraction, okay? So again, development, regeneration, and muscle contraction via the calcium ATPases. That covers our physiology. All right, so the first one that I want to talk about is primary hypothyroidism. Within primary hypothyroidism, there's a bunch of different causes. Let's say that we take these three causes affecting this thyroid gland first, though. Usually, one of the most common issues is that there's antibodies that are acting against particular proteins within the thyroid gland, and we'll talk about those. Or that there's a virus that's actually injuring or damaging the thyroid gland, or particular drugs that are injuring or damaging the thyroid gland. These are very important. Let's first talk about those diseases that are related to antibodies. The first one that I really need you guys to remember is called Hashimoto's thyroiditis. Now, Hashimoto's, first thing I need you to remember is that it is more common in females. Second thing I need you to remember is that it's an autoimmune disease. What does this mean? Autoimmune diseases are a combination, they're multifactorial, but usually it's some type of genetic susceptibility, genes, that are involved in an environmental trigger. And that environmental trigger could be a drug, it could be a pathogen, it could be a pollutant, it could be many different things. But when we're exposed to it, our immune system will phagocytose or take in that environmental trigger or agent. When it does, it expresses a piece of it on its MHC2 complex, right? We know that kind of stuff. And whenever you express a particular thing, let's say here I have a macrophage, I express a particular type of environmental trigger, or a particular antigen, if you will, on my MHC2 complex, what type of cells come and react with that? Your T cells. And when your T cells react with this, the normal kind of response is you're going to produce cytokines. It'll produce cytokines. That'll kind of alert the immune system. Let them know, hey, there's some type of trigger or pathogen or something here that's we don't like. And what that'll do is these pathogens will tell particular B cells, called plasma cells, to produce antibodies. And these antibodies are supposed to be driven against the environmental pathogen. But guess what? For some odd reason, that environmental pathogen or trigger, whatever it is, it looks very, very similar to the proteins that are found inside of the thyroid gland. And because of that, not only do those antibodies go and attack the environmental trigger, they also attack the thyroid tissue inadvertently and lead to destruction. That is also kind of known as molecular mimicry. So that's why I wanted to take a quick second to explain that little process here. And that means that there's some type of genetic susceptibility genes that are causing some type of problem here with the MHC2 complex, where this response is even more exaggerated. And what happens is, with these MHC2 complexes, there's genes that regulate them. And they're called HLA-DR3, HLA-DR5. These are the two primary ones that if there's these genes having mutations, this type of effect can be exaggerated and cause this autoimmune disease that we see. Okay? So that's the big thing I want you to remember. Now, what are the names of these antibodies? These antibodies are exerted against the thyroid peroxidase and the thyroglobulin. So they're called anti-TPO antibodies or anti-thyroglobulin antibodies. Okay? The next one, similar to Hashimoto's, is called postpartum thyroiditis. So postpartum thyroiditis. Now, postpartum thyroiditis, again, you're obviously going to see this in females, but the big thing here is that usually it's within 1 year of birth. So some female within 1 year after giving birth is experiencing this type of issue. Now what happens is usually in pregnancy your immune system kind of the activity of it decreases a little bit. After birth, the immune system kind of revs back up a little bit. And when it revs back up a little bit, sometimes it may inadvertently lead to antibodies that are going to be produced that destroy some of the thyroid tissue, similar to the way Hashimoto's is. But here's the big thing I really want you guys to remember. With Hashimoto's, this is chronic, so these antibodies will continue to keep damaging this thyroid tissue. With postpartum, this is more of an acute issue, and so it will lead to hypothyroidism, but usually there's resolution in time. So after some time, these individuals with postpartum thyroiditis, they'll have hypothyroidism, but usually after that immune system settles down a little bit, they'll resolve and go back into a euthyroid or normal thyroid state. Okay? But again, what is the pathology behind this? It's antibody mediated, and it's the same thing, TPO antibodies and thyroglobulin antibodies. Okay? The next cause is usually some type of viral infection. And that is whenever there's a viral infection that's causing the thyroid to not produce enough thyroid hormone because it's being inflamed or damaged, this is called subacute granulomatous thyroiditis. One heck of a name, right guys? So subacute granulomatous thyroiditis, also referred to as de Quervain's thyroiditis, is usually due to a viral infection. So I want you to remember that it's a viral infection. Now here's what I want you to remember. Whenever you have viral infections, Sometimes this can maybe produce a little bit of an increase in the white blood cell count, but one of the big things that I want you to remember is that usually this produces pain and tenderness of that thyroid gland. But what happens is whenever there's a lot of inflammation, sometimes it can trigger your liver to make particular proteins that can, whenever you do this particular lab test, it can be increased. Do you know what that is? Whenever there's viral infections or inflammation, that inflammation may lead to an increase in a erythrocyte sedimentation rate. So an increased ESR. I want you guys to remember that because that's going to come to diagnostic play later. The next one here related to this inflammation here is also going to be drug-induced. Now drug-induced, the big things that I need you to remember, there's a couple drugs, 3 primary ones. The first one that is really important is amiodarone. This is an antiarrhythmic. The next one is lithium, which is used to treat bipolar disorder. And the next one is iodine 131. You know what we give iodine 131 for? Radioiodine ablation in patients who have hyperthyroidism. They're producing too much. We give that, and it basically inhibits thyroid hormone production by destroying the thyroid tissue. But it can destroy it so much that now you develop hypothyroidism. Now, we've talked about all of these causes, Hashimoto's, postpartum, subacute granulomatous, and drug-induced. We say that it's damaging the thyroid gland. Now remember, if you guys remember from the hyperthyroidism video, that whenever you damage the thyroid gland, what spills out of them a little bit? Thyroid hormone and thyroglobulin. Remember, we talked about that, where it can spill out what kind of things? It can spill out, let's say that we represent the blue here as thyroglobulin, and we represent the red here as thyroid hormone. So it can spill some thyroglobulin out into the blood because of the follicular destruction, and spill some of the thyroid hormone out because of the follicular destruction. What's the problem with that? If you spill some of the thyroid hormone out of these follicular cells, what could that do? It could produce a transient or temporary hyperthyroidism. But after time, as you continue to destroy or inflame or agitate or damage these thyroid follicles, they're not going to be able to produce enough thyroid hormone. And so because of that, eventually their production of T3 and T4 will plummet and drop. Okay, so that's important to remember. The most common one, though, that you will see this with is Hashimoto's thyroiditis. The next one is a very interesting disease. Usually, this is related to other autoimmune diseases, and these are antibodies, but it's a little bit different from the Hashimoto's and postpartum type of thing. And so what happens is, there's other autoimmune diseases that are related to this, and they're producing a particular type of antibody called IgG4 antibodies. And what happens is these IgG4 antibodies are activating particular types of fibroblasts around the thyroid gland. As it does that, as you activate some of these fibroblasts, what does that do? It starts causing fibrosis of the thyroid gland. As you start causing fibrosis of the thyroid gland and replacing the normal thyroid tissue with fibrous tissue, can fibrous tissue release thyroid hormone? No. So in some cases, about 1/3 of patients who develop severe inflammation and fibrosis due to these IgG4 antibodies, and 1/3 of patients, they may develop enough fibrosis that they develop hypothyroidism, okay? Very important here. What is this disease that is related to this IgG4 production? This disease is referred to as Riedel's thyroiditis. What is it called? It's called Riedel's thyroiditis. Now, Riedel's thyroiditis is, again, it's kind of an autoimmune related disease. And it's related to some type of elevation in these IgG4 antibodies. What are other types of autoimmune diseases that you commonly see Riedel's thyroiditis associated with? The big thing I want you to remember is that you can also see this in what's called retroperitoneal fibrosis, non-infectious aortitis, and the big one is autoimmune pancreatitis. That is very important that you guys remember these, okay? So again, usually in all of these related autoimmune diseases, they also have elevated IgG4 that is producing some type of fibrosis and inflammation of these surrounding structures. Again, big thing I need you guys to know is that in these patients, if there is enough fibrosis, enough infiltration due to the fibroblast activation, it can lead to hypothyroidism, okay? And that covers renal thyroiditis. The next one here is usually very interesting, okay? It's dependent upon iodine, and this may sound odd, but you can develop hypothyroidism because of very little iodine, and you can develop this because of too much iodine. Let's explain why. If someone is iodine deficient, so let's say that they have low iodine, or if the opposite pole here, you have high iodine. Let's make sense of how these could potentially lead to what? If you have this issue, the whole idea behind this is that this may lead to a decrease in T3 and T4, thyroid hormone, right? How? It's really simple. What did we need iodine for when we talked about the synthesis of it? We talked about it for a reason, right? What do we need iodine for? We needed to add the iodine onto thyroglobulin. So if I have decreased iodine, I don't make enough iodinated thyroglobulin. And so because of that, if you have decreased iodinated thyroglobulin, can you make functional thyroid hormone? Remember, thyroid hormone, in order for it to be functional, it needs iodine on it. If you don't have that, you can't make it. That's pretty straightforward, right? This is the most common cause worldwide for hypothyroidism. Hashimoto's is the most common within iodine sufficient areas, and iodine deficient hypothyroidism is the most common cause worldwide, okay, where areas that they're iodine deficient. Foods are not fortified with it. The opposite one though, whenever there's high iodine, I know you're probably like, whoa, what the heck, how does this do it? There's a particular mechanism called the Wolff-Chaikoff effect. And all this says is that if you give too much iodine to somebody, really high amounts of iodine, what it'll do is the high amounts of iodine will inhibit T3 and T4 synthesis. How? If you have too much iodine, what it'll do is it'll inhibit a particular enzyme called thyroid peroxidase. It'll say, hey, there's too much thyroid hormone that's being produced. There's too much that you guys are making here. We need to slow this down. I'm going to inhibit you, thyroid peroxidase, from continuing to do that process there. Oh, proteolytic enzymes. You guys are cleaving too much iodinated thyroglobulin and making too much thyroid hormone. I'm going to inhibit you. So it'll also inhibit the proteolysis. And the overall effect of inhibiting the thyroid peroxidase, inhibiting the proteolysis due to too much iodine via negative feedback leads to decreased thyroid hormone synthesis. So that gives us the primary reasons that someone would develop hypothyroidism due to a thyroid issue itself. Now, let's talk about central hypothyroidism causes. So let's take in a scenario here. Let's say that it's a hypothalamus issue. You guys got to remember, what does the hypothalamus make? What is that hormone? It is TRH. TRH then does what? It tells the anterior pituitary to make TSH. And TSH does what? It tells the thyroid gland to make thyroid hormone. Okay? So as a result here, it's going to tell the thyroid gland, hey, make thyroid hormone. Let's say that there's an issue where there's something wrong with the hypothalamus, or there's something wrong with the pituitary. Let's take the first scenario. Something's wrong with the hypothalamus. If the hypothalamus is not working, what's going to happen to the TRH production? It's going to drop. What happens to the TSH production? That's going to drop. What happens to the thyroid hormone production? That's going to drop. That's hypothyroidism. Another scenario, what if there's something wrong with the pituitary, anterior pituitary? It's not making a lot of TSH. Then what's going to happen to the thyroid hormone? That's going to drop. Now here's the interesting effect here. Usually, let's say that we took this scenario and avoided this issue here. We don't even know that this is going on. If someone has hypothyroidism, what is the normal negative feedback type of effect? I know you guys know this. The normal feedback mechanism is that whenever there's low thyroid hormone, that's going to come over here and stimulate the hypothalamus and stimulate the anterior pituitary to make more TRH and more TSH. But if there's something wrong with the hypothalamus or something wrong with the pituitary, is it going to be able to make TRH? No. So it won't respond, and TRH will continue to be low. Or if there's something wrong with the anterior pituitaries, they're going to respond and make TSH. No. So even though there's hypothyroidism, it's still going to be low. That's very important diagnostically. Now, the next question that you should have is, what in the heck can cause the hypothalamus to have a problem or the pituitary to have a problem? And it's actually relatively easy. If you think about it, what if somebody experienced some type of traumatic brain injury? If they had a traumatic brain injury and that damaged the underlying brain tissue, particularly the hypothalamus. Or what if they have some type of tumor near the hypothalamus, and that tumor is compressing on these nuclei and affecting their ability to make TRH. That could be another reason. But the overall effect here, regardless of what the cause is that they have some decrease in TRH production. If you take the other scenario, where you take into consideration the anterior pituitary, what's going on with the anterior pituitary that it's not making TSH? A big one here is that it could also be related to some type of trauma, maybe an underlying traumatic brain injury. But you know what another one is? It could be a tumor, but the big one that I really need you to remember is an underlying infarction. There's a particular name that can happen in whenever someone gives birth and they bleed a lot and they lose too much blood, they don't get enough blood going to the pituitary gland, and the actual pituitary gland can infarct and affect its ability to not just to make TSH, but a bunch of other hormones that it makes. What is that condition called? Very important you guys remember it. It's called Sheehan syndrome. And Sheehan syndrome is associated with postpartum hemorrhage, not getting enough blood flow to the pituitary, infarcting, and then what's the result of that? Decreased TSH, resulting in decreased T3 and T4. Ba-boom, baby, we good. All right, so congenital hypothyroidism. So this issue here, I want you guys to remember that there's a problem with the development, the maturation of the thyroid gland, or that there's one more issue, and that there's not enough iodine. Same thing in adults. So what would be the issues here? The first one that I want you guys to remember here is that there could be antibody-mediated destruction. And here's the big thing. This antibody-mediated destruction of the baby's thyroid gland is due to the maternal antibody-mediated destruction. Very, very important there. The reason why has not been completely figured out, but again, what happens is these antibodies injure and destroy the baby's developing thyroid gland. If the baby's thyroid gland can't develop, is it going to be able to make thyroid hormone? No. So I know it seems super obvious, and it's because it is that if there is this continuous damage and not proper growth of the thyroid gland, it'll lead to hypothyroidism. The next thing is, what if we don't even form the thyroid gland? What would that be called? So what if I don't develop the thyroid gland? Not developing the thyroid gland is called agenesis, so thyroid agenesis. That could be one reason. The other reason is the thyroid gland forms, but it doesn't form completely, and it forms abnormally. If that happens, what is that called? That is referred to as thyroid hormone dysgenesis. So it could either be not forming the thyroid gland, meaning that you don't produce any thyroid hormone, or abnormally forming the thyroid gland and producing very little thyroid hormone. So in this situation, you may produce no T3 and T4, and in this scenario, you may produce very little T3 and T4. So again, this is a developmental issue that's becoming a problem here. So it could be maternal antibody mediated, not forming it, abnormally forming it. What's the last one here? The last one here is that there's something intrinsically wrong with the follicular cell proteins and enzymes. You know, there's that beautiful little enzyme that's present in the follicular cells called thyroid peroxidase. What happens, do you think, if I decrease the expression of this enzyme or I don't express it at all? Am I going to be able to make thyroid hormone? No, because what did TPO do? It helped to oxidize the iodide into iodine and add iodine onto thyroid globulin, making iodinated thyroid globulin. If I don't have this enzyme, what's going to happen to my thyroid hormone production? It's going to significantly drop, where I'm not going to be able to make T3 and T4. There's a particular name for this. It's called dysharmonogenic Goiter. Let me explain why there's a goiter. Now, TPO, what does it do? We already know it undergoes oxidation of iodine and adds iodine onto thyroglobulin. If you don't add iodine onto thyroglobulin, can you make thyroid hormone? No. That means, can you release any of that thyroglobulin out of that follicle that we showed over there? No. So that thyroglobulin continues to build up in those follicles more and more and more and more and more because it's not getting released out into the blood as thyroid hormone. And that makes a big old sucker in the neck called a goiter. And that's referred to as dyshormonogenetic goiter due to a defect within the TPO enzyme. The last cause of congenital hypothyroidism is usually due to iodine deficiency. And it's the same thing that we talked about before. If you don't have enough iodine, you can't make what? Functional thyroid hormone. Could they develop a goiter? Absolutely. Anybody with iodine deficiency that's not releasing thyroid hormone and accumulating thyroglobulin can develop a goiter. So again, this will lead to decreased T3 and decreased T4. Now, we're going to talk about the clinical features next for all hypothyroidism. But congenital hypothyroidism is very interesting because there's a high yield mnemonic that I want you guys to remember for someone who has congenital hypothyroidism. They can have all these symptoms as we're going to talk about, but they also have these additional features that you guys need to remember. What are they? You can remember the clinical features of someone with congenital hypothyroidism, whether it be due to any of these causes. One of the big ones is actually iodine deficiency, but it can be remembered by the 7 Ps. The first one is they have a pot belly, so they got a big old belly. They're pale. They have a puffy face. They have a protuberant tongue. They have a protruding umbilicus. They have poor brain development. And last but not least, they have prolonged neonatal jaundice. So these are the big things that I need you guys to remember and take away if someone has congenital hypothyroidism. These are the common clinical features that you will see associated with these based upon this 7P mnemonic. All right, now that we've drilled in the pathophys and the causes, let's really start talking about the clinical features related to the pathophysiology. All right, Ninja Nerds, so now let's start talking about the clinical features associated with the pathophys. This is where you guys really need to remember all that phys that we talked about. It's coming back. There was a reason why I went over it, right? Not for my own good. It's to help you guys to really understand the clinical features. So the first thing that you need to know with someone who has hypothyroidism, a common manifestation can be a goiter. And again, we already talked about this. The whole concept behind someone developing a goiter is because they're not releasing the thyroid hormone from the thyroid follicles. And that may be because of an iodine deficient situation. That may be because of they're actually continuously destroying the thyroid gland. And as that thyroid gland is being destroyed, it's continuing to hypertrophy. Whatever it may be, they can develop goiters. So there's many different reasons for goiters. One of the common reasons is that if they're iodine deficient, they're not releasing functional thyroid hormone. In other words, that thyroglobulin that you were producing and putting into that central portion, it's not being iodinated and you're not pulling it into the cells to release thyroid hormone. It's just accumulating, accumulating, and accumulating. Okay? That's one thing. The next thing is, do you guys remember every nucleated cell that was capable of performing metabolism? We're just going to do what? Decrease the activity of it. We're going to decrease the activity of everything that we talked about over with physiology. So if I decrease the metabolic activity of my cells, right, particularly, remember what we said? If I decrease the metabolic activity, I'm going to decrease glycolysis, I'm going to decrease lipolysis, and I'm going to decrease glycogenolysis. That means that there's going to be less metabolism, less ATP that's being produced. If that happens, that means my metabolism is really shutting down, it's really decreasing. If I have a decreased metabolic activity, am I going to break down lipids and glycogen and stuff as well? No. So because of that, what happens? You gain weight. So one of the effects of this is weight gain. The next thing that I need you guys to remember is that whenever you guys perform cellular respiration, you break down glycogen, you break down glucose, you break down lipids, every metabolic activity that goes through aerobic cellular respiration, you generate CO2, you generate water, and you generate ATP. But there's one more byproduct that you generate: heat. That's a natural byproduct of cellular metabolism. If you're having decreased metabolism, are you going to generate as much body heat? No. So because of that, there's going to be decreased heat production, and this decreased heat will lead to a low body temp, sometimes referred to as cold intolerant. So they can experience weight gain. They can experience a decrease in body temp. Another thing is, if you're having a decreased metabolism of these substances, what happens is it also changes your appetite. And so because of that, in situations of hypothyroidism, where they have this weight gain, they have a decreased appetite. Okay, and that could also be because of the gut-brain signaling mechanisms. I don't want to get too deep into it, but again, big thing: weight gain because of decreased metabolism, and decreased body temperature because of decreased heat from cellular respiration. Boom. The next effect is on the heart. Remember, we said it increases the beta-adrenergic receptor sensitivity. Well, if there's decreased thyroid hormone, we decrease the beta-1 adrenergic receptor sensitivity. Remember what we said that would do? Well, and before it said if we had it, it would increase heart rate a little bit and increase contractility a little bit. Well, if we have less of that sensitivity, what is it going to do? It's going to lower the heart rate. So it can maybe lead to a little bit of bradycardia, and it's going to mildly decrease the contractility, not as significant as the heart rate. So there'll be a significant drop in heart rate, a small drop in contractility. One more thing. Remember, we said that thyroid hormone regulates the vasomotor tone on our blood vessels. In other words, constriction, dilation. Whenever you have little thyroid hormone, guess what? It tips the balance towards vasoconstriction. So if I increase the vasoconstriction, and this may seem odd, I know, but this is what the mechanisms have shown us, that's going to lead to squeezing and clamping down on the blood vessel. What does that do? That decreases diameter, it increases resistance, and does what? Increases blood pressure. You're like, whoa, Zach, I thought you said in hyperthyroidism it also increases blood pressure. It does. Remember our video on the pathophysiology of hypertension? We said hypo and hyperthyroidism both can be causes for secondary hypertension. Even though it is weird, yes, it is possible. So they can experience bradycardia as well as hypertension. Okay, the next thing here. Remember I told you that thyroid hormone is important for osteoclast and osteoblastic activity. That is very important, and maintaining the balance between it. But you know what else I told you? It's important for bone growth and maturation. If you don't have enough thyroid hormone, it's very problematic whenever you're developing and maturing bones. Very important. And so decreased thyroid hormone leads to decreased bone growth and bone maturation. And you know why that's a problem? Whenever your skeletal system is developing, it's not going to have all the things it needs to continue to grow. So what will happen? They'll develop a short stature. So someone can develop a short stature as a result of this. Boom. Okay, now what about the effect on the nervous system? Now, we said that normally thyroid hormone increases sympathetic nervous system activity. Well, we have less. So that's going to decrease sympathetic nervous system activity. So now what would that lead to? That can lead to depression, because you're having a little bit more parasympathetic drive in this situation when you have less sympathetic drive. It can lead to fatigue, and it may even lead to a very ambiguous term referred to as lethargy. But another one is that thyroid hormone is also important for your memory circuits, Papez circuit that we talked about in neuro. And so because of that, less thyroid hormone may have less activity within your memory circuits. And so that may lead to some memory loss or deficits or mental dulling, if you will. Okay? The next thing is, if you have less thyroid hormone, it affects your reflex pathways. And what happens is something very interesting, where when there's less thyroid hormone, you can test a deep tendon reflex. And that what happens is with decreased thyroid hormone, their deep tendon reflex will occur, but it'll occur much more delayed than usual. So they can have what's called delayed deep tendon reflexes. There's a particular name for this. It's called Woltman's sign. Okay? All right. That covers that. The next one here is the GI tract. Remember, we said it normally increases GI motility and increases GI secretions, but we have hypothyroidism. So it's going to decrease GI motility and decrease GI secretions. If I don't move things through the GI tract as much, it's going to absorb more water, absorb more of the electrolytes, and become more hard and stiff. What is that going to do? It's going to form a big old poop ball, and that's going to cause constipation. And nobody want no constipation, because guess what? Whenever you try to poop that sucker out, you're going to end up with hemorrhoids, okay? So constipation could also be another issue that could be seen with this. All right, let's come back up here and keep working our way down. The next issue that you can start to see is that, remember, we said that this helps the muscles. It plays a role within muscle contraction, and it plays a role within muscle growth and regeneration. What if I don't have enough thyroid hormone? Is it going to grow as well? Is it going to be able to regenerate whenever it's been stimulated or injured? No. And because of that, due to decreased muscle growth and regeneration, this can lead to what type of effect here? It can lead to myopathy, where there's damage to the muscle tissue. Whenever there's damage to the muscle tissue, particularly damage itself, it can spill out a lot of a particular enzyme called creatinine kinase. So whenever there's significant amounts of myopathy or damage to the muscle tissue due to not being able to grow it or not being able to regenerate it when it's injured, it spills a lot of these CK out. The next thing is, with progressive myopathy and injury to the muscles and not being able to regenerate and grow, what happens to them? They become weak. And so they develop weakness. And you know where this weakness is most commonly seen? Within the proximal muscle groups, shoulder, hip areas, okay? The last thing I need you guys to remember is that it also is going to decrease muscle contraction. Again, playing a role with that weakness, not just because of the myopathy, but also decreased muscle contractions. How? It decreases the expression of what? Remember, it maintains the activity of calcium ATPases. If we have less of that, do we have as many calcium ATPase activity? No. So there's decreased calcium ATPase activity. Think about that as less calcium within the cell when you need it. If there's less calcium in the muscle cell, you're going to be able to contract the muscle cell as well. No. That leads to decreased muscle contractions, playing a role within proximal muscle weakness. But boom, we good, baby. All right, let's move on to the skin. The skin, what do we do? Normally it increases blood flow to the hair, the skin, the nails, and helps to play a role within sebum and sweat gland production. If you have decreased blood flow because you have hypothyroidism, what happens with that? Well, now, with decreased blood flow, you're not providing as much oxygen and nutrients to the hair, the skin, the nails. There'll be hair loss. And you know there's a particular area where they lose hair, which is kind of a buzz term kind of thing, where they lose it on the outer third of the eyebrows. It's called Queen's ensign. So remember that. Sometimes that may pop up on your exams, is a Queen's ensign is hair loss on the outer third portion of the eyebrows. The other thing is that you're not providing enough blood flow to the nails. And so the nails can become kind of brittle and thin. Right? The other thing is that the skin is not getting enough blood flow. So the skin is not getting enough blood flow, so it's going to appear more dry as well. So they're going to appear more pale, actually, because you're not getting a lot of blood flow, and a little bit dry because you're not having as much secretions, right? So that goes back to this next thing. So we have the hair, skin, nail effect. But remember, we have to think about it plays a role within sebum and sweat gland production. If there's decreased sebum production, what does that lead to? So decreased sebum production is going to lead to a lot of dry skin. And if you're going to have decreased sweating because you're not having as much activity of those eccrine sweat glands as well. Beautiful. Now let's move on to the liver. The liver, remember, what did thyroid hormone do? It maintained the receptors. What type of receptors on the liver? It maintained the activity of the LDL receptors that are expressed on your liver to pull LDL from the blood. If you have low thyroid hormone, what's going to happen to the LDL receptors? You guys already know, right? You're going to drop the LDL receptors. So now these receptors are gone. If you have LDL floating here through the blood, and also another one is you pull triglycerides into, there's other things for triglycerides as well. But if you're trying to have LDL, primarily LDL get pulled out of the blood and into the liver, you need LDL receptors. If you have less of these LDL receptors, are you going to pull as much LDL into the blood, into the liver? No. So the LDL and triglycerides will build up, and you can develop hypercholesterolemia and hypertriglyceridemia. Okay, so that could be problematic. All right, so the next thing is, we talked about the liver, the next thing is reproductive system. This one's very interesting. If you guys remember from the hyperthyroidism, we talked about sex hormone binding globulins here. Hypothyroidism can affect those sex hormone binding globulins like hyperthyroidism, but not as significant as whenever someone's hyperthyroid. The reproductive effect actually comes from something very interesting known as hyperprolactinemia. Okay, so I want you to remember, reproductive effects from hypothyroidism is due to hyperprolactinemia. Reproductive effects from hyperthyroidism is due to the increased sex hormone binding globulins. So, with hypothyroidism, how does this work? Well, here's what I want you to remember. In hypothyroidism, someone is their thyroid glands, like say primary issue, they are making less thyroid hormone. The natural effect that we talked about before is that this will go back to the hypothalamus. The hypothalamus will respond to this low thyroid hormone and make a hormone called what? Thyrotropin releasing hormone. It'll make more of it. That thyrotropin releasing hormone, when you increase the production of it, it stimulates two cells in the anterior pituitary. One of them is it releases an increase in TSH because you need more TSH to try to drive this thyroid hormone level up. That's one effect. All right, so not only is there an increase in this TSH, but there's also an increase in prolactin whenever there's these higher than usual levels of that TRH. So remember that. Elevated levels of TSH as well as elevated levels of prolactin. What's the problem with that? Whenever you have high levels of prolactin, that loves to inhibit FSH and LH production. When you inhibit FSH and LH production, you inhibit the production of testosterone and you inhibit the production of estrogen. That's very important. Why? Because in males, what happens if you have very low testosterone? We're going to put test there. What would happen? Well, remember, we need it for sperm production. If you don't have enough testosterone, that leads to a decreased sperm production. What happens to the sex drive? Because it plays a role in sex drive. There's a decreased sex drive, also known as a decrease in libido. What else? It's also important for masculinization of the male. So because of that, decreased testosterone leads to decreased masculinization, particularly within the breast tissue, and they develop little moobs called gynecomastia. Now, these are the primary effects, right? So you can see a decreased sperm production, you can see decreased sex drive, you can see gynecomastia. If you want to remember one more, it also plays a role within the activity of the, so it can lead to erectile dysfunction as well. The next thing is what can this do within the females? So remember, there's decreased estrogen production. If there's decreased estrogen, we need this in order for ovulation to occur. So if there's not enough, there's decreased ovulation. What happens if there's decreased ovulation? Infertility, because if you don't pop a little oocyte out there to be fertilized by the sperm, then you can't actually develop a potential pregnancy. So they can lead to infertility. It also is important for regulating your menstrual cycles, maintaining the normalcy of menstrual cycles. If there's less of it, that can lead to oligomenorrhea. And if there is not enough at all, and it affects it to the point where you don't have any menstrual cycles, this can lead to amenorrhea. One more thing. Whenever there's high prolactin levels, not only can it exacerbate the gynecomastia within males, but it can also do something within females, very interesting, where it's important for milk production. We know that prolactin is important for milk production. But sometimes it can lead to inappropriate milk production within females, and it can lead to milk actually being let out from the nipple, and that's called galactorrhea. Galactorrhea. So remember that issue as well. Okay, I think we really drilled home the reproductive effects. Let's take it home with the last one, which is this fibroblast activity. Now, remember what I told you, the thyroid hormone regulates the activity of the fibroblast glycosaminoglycan production and degradation. Whenever there is low T3 and T4, there's still going to be some GAG production. But here's the problem. So the GAGs will still be produced. But you know what happens? The degradation of the GAGs, that's not going to happen. So what happens is this results in decreased degradation. So the decreased degradation of GAGs. And that leads to what? an increase in the amount of glycosaminoglycans. Why is that a problem? Whenever there's a lot of glycosaminoglycans, that pulls a lot of water to where the glycosaminoglycans are. And so if you pull a lot of water where there's a lot of glycosaminoglycans, it can lead to that space being a little bit more edematous. Where do we see these gags really accumulating, particularly within the body? The first one is we see these gags accumulating in the dermis, within the actual tibial region. And it pulls a lot of water into that area, leading to a lot of edema where the tibia is. And this is called pre-tibial myxedema. That's the first thing I want you guys to remember. So pretibial myxedema is due to a lot of gags within the dermis because of less degradation of the gags because of hypothyroidism, and that causes edema there. The next thing is it can also accumulate in the tissue, in the dermis around the eyes. And as it does that, that leads to a lot of water being pulled into those tissues. If you pull a lot of water into those tissues, what's going to happen? It's going to lead to edema. And this edema that's occurring around the eye is called periorbital edema. All right, beautiful. So we have pretibial myxedema, periorbital edema. There's one last one, and this is actually probably the coolest one. The gags can also accumulate near the carpal tunnel and the tissues, the connective tissue and muscles around the carpal tunnel. If that happens, a lot of water gets pulled into the tissue around the carpal tunnel. If you pull a lot of water into there, what's that going to do? It's going to cause edema. And that edema around the muscles and fibrous tissue and tendons in that area is going to become a little bit more edematous and put pressure on that little orange nerve that's running through there. You know what that is? The median nerve. And whenever you compress that sucker, it's called carpal tunnel syndrome. And that could be due to what? An increase in gags because they're not being degraded because of the hypothyroidism. So again, increase in gags because of decreased degradation leads to pretibial myxedema, periorbital edema, or carpal tunnel syndrome. We hit all of the clinical features. Let's go into the diagnostics. All right, beautiful. Now let's start talking about the diagnosis of hypothyroidism. The first thing that we need to talk about is it primary versus central? That's the first question that we need to ask. And this should be very easy. We've already kind of gone through this a little bit. So the first thing is it primary? How do we determine if it's primary or central? The first thing that you need to remember is that you have to order what's called thyroid function tests. And with a thyroid function test comes two things. Free T4 is going to be one of the things that you obtain. And the second thing is going to be a TSH. One other thing that we may add on here for the simplicity of this diagnosis part is a TRH. We might add that one on, okay? So let's talk about what would we get? What would it look like with these three parameters versus primary and central? So if someone had primary, so let's say that we have primary hypothyroidism, low T3 and low T4 in this situation here. In this scenario, we know that hypothyroidism, all of these, primary versus central, all of them are going to have low T4, right? We know that. So in this scenario here, this first scenario, is we're going to see a low free T4. Now, if someone has a primary hypothyroidism, meaning it's a thyroid issue, there's nothing wrong with the pituitary gland. What should happen, negative feedback mechanism-wise, low free T4 should tell the anterior pituitary to do what? It should tell the anterior pituitary to make TSH. And so a response to that is it would stimulate the anterior pituitary, and the anterior pituitary would increase its production of TSH. So if someone had primary hypothyroidism, they would have low free T4 and high TSH. Now, let's take, for example, the central causes. The central causes, you have to remember, there was two types. There was hypothalamus, that was one of the issues. There was a hypothalamus lesion, or there was a hypothalamus trauma or something of that nature. And then the other one was there a pituitary issue. So there was something wrong with the pituitary. How do we know which one it is? Again, same concept here. They're both going to have a low free T4. So both of them will have a low free T4 because it's hypothyroidism, right? Generally, if someone has a normal hypothalamus or a normal anterior pituitary, let's say hypothalamus first, what would happen if they have low free T4? The hypothalamus, it would tell the hypothalamus, hey, you need to make TRH so that you can tell the anterior pituitary to make more TSH. But the hypothalamus is not responding because there's something wrong with it. So the TRH production is going to decrease. It's not going to respond to the low free T4. And as a response to that, that's going to lead to decreased TSH. And that decreased TSH is going to lead to a continuous low free T4. Okay? So that's how we would determine hypothalamus. It's low TRH, low TSH, and low free T4. If there's a pituitary problem, that means that there's low free T4. Again, it would tell your hypothalamus and your pituitary, but generally it can also tell the pituitary. And what happens is if there's low free T4, the pituitary, the anterior pituitary should respond and say, okay, hey, you're telling me there's low free T4, I got you, baby. I'm gonna go ahead and produce your TSH for you. But there's a problem with the pituitary. If there's a problem with the pituitary, it's not going to make the TSH. It's going to cause a decreased TSH production. A decreased TSH production will continue to lead to low free T4, and again, the pituitary will still not respond, and the TSH production will continue to drop. So, if you had to differentiate, primary, they have low free T4, high TSH. Central, if it's hypothalamic, they both have low free T4, but hypothalamus has low TRH, low TSH, and pituitary would have low free T4 and just low TSH. What's another way that we could differentiate if it's hypothalamic or pituitary? Once we've kind of gotten these lab values back and we find, there's something wrong with either the hypothalamus or the pituitary, get an MRI. So obtain an MRI. An MRI may be the thing that you need to determine, I see there's a tumor in the hypothalamus. There's some hemorrhage near the hypothalamus. There's some infarction in the pituitary. There's some injury to the pituitary. That may give us and clue us into really what's the problem, okay? All right, now that we've gone through this and we've determined, all right, we've figured out that it's actually central. Boom, we know how to go about that way. But now we have primary, and there was a ton of different types of primary causes. How do I know what the cause of the primary hypothyroidism is? The way that we go about this is a couple different ways. Let's actually go through a couple of those and write them down. The first one is we said Hashimoto's. What is one way that we can determine Hashimoto's thyroiditis? Well, one way is we could say, all right, more common in females. That could help epidemiologically. But the next thing we should say is, okay, we remembered that they have positive TPO and positive anti-thyroid globulin antibodies. So I would have antibodies against TPO antibodies, and I would have thyroid globulin antibodies. That would be one thing that would come back positive. The next thing is, remember I told you that whenever there's injury to the thyroid gland, what leaks out from that between the follicles? Thyroid globulin. So another thing is they could have elevated serum thyroid globulin. But there's one more thing. If we wanted to take it to the next level and really come up with a definitive diagnosis of Hashimoto's, the only particular definitive way is to do a biopsy and to actually look at the tissue for the particular types of infiltration. So biopsy would be the definitive diagnosis, okay? All right, so that's one way we could go about this. Another thing is you could do the radioactive iodine uptake. There's no need to, but it would show low uptake or no uptake. Okay? The next thing that we said is postpartum thyroiditis. So if someone has postpartum thyroiditis, what's going to be the issue with this one? Postpartum thyroiditis. Again, we can take into consideration their history, right? It's within less than 1 year since birth. That could be one particular thing. Again, you can check the TPO antibodies. And you can check the thyroid globulin antibodies. They'll be positive. But what's the big thing I told you that you guys need to remember with this condition? Usually, they may have hypothyroidism, but over time, they may return to euthyroid states. It's acute, not chronic in comparison to Hashimoto's. So it's acute, and that means that they may return to euthyroid. All right, beautiful. The next one we said was drug-induced. This, again, is another easy thing to figure out. You want to know why? hey buddy, or hey ma'am, what you taking any medications like amiodarone or lithium, or have you had any radioiodine ablation therapies recently? Oh, you have? Okay, well this could be the reason why. And so that's something that we'd have to look at, is look at their history. So do they have a history of a use of amiodarone, lithium, or have they had iodine 131 recently for radioiodine ablation? That could be reasons. And again, these are also injuring the thyroid gland, so they may also have an elevated serum thyroid globulin. So we'll postpartum thyroiditis. But again, it's as simple as saying, oh, you taking any of these medications? Oh, I see you are. Okay, beautiful. The next thing we said is renal thyroiditis. Renal thyroiditis is actually a little bit more difficult to identify, and there's something important that we could actually use as key indicators that it could be renal thyroiditis. So one thing that you'd have to do is, obviously this would produce from that fibrous tissue that they have, it can produce a very hard and painless thyroid. That's a very important thing I want you guys to remember. They're a very hard and painless thyroid. But because they develop all this fibrous tissue around them, it can compress. It can really compress some of the nearby structures and just be a big fibrous tissue mess in that area. What are some of the structures that are near the thyroid gland? Take it as simple as possible. Compress what? What if it compresses the esophagus because of that fibrous tissue? What can that lead to? Dysphagia. So if they present with maybe a hard nodule with dysphagia, or it compresses onto the trachea, what can that lead to? Maybe that leads to dyspnea, difficulty breathing. Maybe it compresses the recurrent laryngeal nerve. That may lead to hoarseness. So you see how they may have compressive symptoms that is similar to actually like a tumor. And so if they have a hard kind of a painless nodule, they have these compressive symptoms, you may be thinking, oh man, I think these guys have thyroid cancer, anaplastic carcinoma maybe, because that presents similarly. The only way that you can really determine that is that you'd actually have to go and you can check their IgG4 antibodies. Not that great of a test. They may come back positive, but the best way is to go in and take a biopsy. And once you biopsy, you'll be able to determine, is this cancer or is this just a lot of fibrous tissue related to the renal thyroiditis? Okay? All right, the next thing that we need to do is, we need to test for that. We need to think about subacute. What if they have subacute granulomatous thyroiditis? So what else could they have? Subacute granulomatous thyroiditis. How do I determine this? Well, they may present with a elevated ESR. Remember I told you that? That's one of the things that we may see. The other one is they may present with flu-like symptoms. So they may present with muscle aches, joint aches, maybe a low-grade fever. What else? A painful and tender thyroid upon palpation. That's very, very important, okay? So that's one of the ways that we can help to differentiate subacute granulomatous thyroiditis from some of these other ones. The next thing that you want to be thinking about is, what if this is an iodine issue? It's simple. Check their iodine. So is this an iodine deficiency? Okay, is this an iodine deficiency? Check the serum iodide. Okay? Or, again, take into consideration their area. Is this an area that particularly iodine deficiency may be more endemic? Okay, that may also be another thing. And again, remember I told you that sometimes if you have too much iodine, it can exert that Wolff-Chaikoff effect, which can also cause a negative feedback inhibiting thyroid hormone synthesis. That's very short-lived. It doesn't last very long. So it's not something that you're going to see with a chronic hypothyroidism. So don't worry too much about that diagnosis. But again, low iodine, simple, check the iodine. Okay. After we've gone through this has helped us to rule out particularly any of the primary hypothyroidism. One of the big things I really want you guys to talk about, because you see it a lot in medicine, is that they can have associated conditions which may key you into the hypothyroidism as well. I really want to take a quick second to talk about that. All right, so what are some of these associated conditions I want you guys to be thinking about? We kind of talked about a little bit of these later, but some of the things that I want you to also be considering to order are things that you may get tested on your boards. It may not be just this picture-perfect diagnosis kind of step-by-step process. They may give you very little ambiguous symptoms, clinical features, and then a couple kind of like abnormal labs. And I really want you guys to interpret these labs and understand what they're telling you with respect to hypothyroidism. So remember, one of the things that we said is that whenever you have hypothyroidism, it inhibits the LDL receptor uptake. Okay? And so what could that result in? High LDLs. So be on the lookout when someone has high LDLs within the blood or high triglycerides in the blood and presenting with the clinical features of hypothyroidism. Again, something to think about. Not always truly diagnostic, but something to think about. The next thing is, remember we also said that whenever someone has significant hypothyroidism, it damages the muscle cells. They don't regenerate, they cause less muscle contraction, and so because of that, they may have elevated creatinine kinase levels. So that may also be something to think about, okay, when you're having a person present with these clinical features. The next one that I want you guys to remember is that, remember, it decreases glycolysis, glycogenolysis, and lipolysis, but there's one more pathway that we didn't mention, and this is another one. It decreases gluconeogenesis. This is a big one. And because of that, if there's really low thyroid hormone levels, this can result in decreased glucose levels within the blood. Hypoglycemia. So if someone also presents with hypoglycemia, be on the alert for that. The last thing I want you guys to remember here is that whenever there's hypothyroidism, right? Hypothyroidism, there's a mechanism that's being looked into that what happens is this may actually stimulate ADH production. And ADH may increase water reabsorption. Now, if you increase water reabsorption, what's the problem with that? If it happens a lot, it may dilute the sodium that's actually in the blood. If you dilute your sodium enough, it can cause what's called a hypotonic hyponatremia. Okay, so sometimes you may also see a patient with a hypotonic hyponatremia. Be on the alert for, again, someone with hypothyroidism. Okay, so these are a couple of these associated things that I want you guys to be looking at that can add and aid in the diagnosis of hypothyroidism. But again, not diagnostic, like definitive diagnostics. The next thing is congenital hypothyroidism. This will finish up for the diagnoses. Within 24 to 48 hours after a child is born, it's actually mandated by law that they test for congenital hypothyroidism. And so one of the things that they do is they check TSH. So again, within 24 to 48 hours post-birth, by law, they have to check a TSH, okay? Now think about this, without us even knowing, if someone has congenital hypothyroidism, we said that it was primarily an issue where the thyroid gland wasn't developing, it was being destroyed, you didn't have enough iodine, or the enzymes were all jacked up, we're not making thyroid hormone. If there's low thyroid hormone, but the pituitary is intact, what would happen to the TSH? It would come back high. So if you checked a TSH on the little baby and it came back high, that's making you think, oh, hypothyroidism, how do I confirm? What do? Order a free T4, and that free T4 would come back what? Low. And that may key you into saying that this patient has congenital hypothyroidism, along with the clinical features that we talked about as well with the 7 Ps. Okay, that keys up our entire diagnosis. Let's finish up with treatment and then a quick complication. All right, so the next thing is hypothyroidism. How do we treat it? It's actually probably the easiest thing possible. Give them thyroid hormone, right? So how do we do that? There's a particular drug, a synthetic thyroid hormone, which is called levothyroxine. And this is literally T4. It's literally synthetic T4. So whenever you give someone levothyroxine, what happens is that T4, that synthetic thyroid hormone, gets taken up into your target cells. And then you remember what the mechanism is? T4 has to get deiodinase, remove an iodine, and convert it into T3. And then T3 binds to an intracellular receptor, activates genes, and increases the expressions of particular proteins that increase metabolic activity, exert all of the physiological effects that we saw over there. Basically trying to reverse the hypothyroidism. That is the easiest concept. You can also, there is another drug, and you basically can give T3, leothyronine, but it's not as effective as T4, levothyroxine. So again, this will be your first line treatment. What I really wanted to take a quick second to talk about, because this is actually more important than just knowing the drug, is knowing how is this drug even effective? Am I giving them the right dosage? Am I giving them too much? How do I know? Think about this. Let's say that you have a patient here who you give T4 to, right? And let's take the two scenarios here. Let's say that you actually have the first one, which is you don't give enough of that thyroid hormone. If you don't give enough of the thyroid hormone, what does that do to the pituitary gland? What was the response from that? The pituitary gland should respond by doing what? Increasing the TSH production, telling the thyroid gland, hey, make more thyroid hormone if you can. If you're giving too much T4, too much levothyroxine, then what would the problem be? Then this would tell the anterior pituitary, hey, anterior pituitary, too much of me, you gotta chill out, bro. Decrease the TSH production. So let's say that you give someone levothyroxine, but you give them too little. They're going to have a high TSH when you monitor to see, hey, is it this drug, if I'm giving them too much, is it effective? You get the person's lab back after they've been on the levothyroxine for a little bit, the TSH comes back high. What does that mean? I'm not giving them enough. Increase the dosage. So that's very important. I want you guys to know that. Increase the dose of the free T4 or the thyroxine, and then recheck. If they come back after they've been on the levothyroxine for a little bit and their TSH is low, that means that you're giving them too much. What do? Drop the dose of the free T4, or in this case, the levothyroxine. Pretty straightforward, pretty simple, right? Not too bad. The last thing I need you guys to know, because it's very important for real life scenarios, because a lot of people could be on other medications that alter the T4 levels as well. And so that's very important. Things that are the most significant here is that, let's say that somebody is on an oral contraceptive and that contains a lot of estrogen in it. If that's the case, what this does is it actually increases the concentration of what's called thyroxine binding globulins. What does that do? That binds the T4. In this case, it binds more of the levothyroxine. So let's say that you give them a dose of levothyroxine, but they're on this estrogen pill. It's going to increase the amount of TBG, which is going to decrease the amount of circulating free T4. That means that even though you're giving them thyroid hormone, this estrogen may effectively lower the amount of circulating T4. So what will you have to do sometimes in someone who's on estrogen? You may have to increase the dose. So you may have to increase the dose in these scenarios. The last situation is another commonly given drug that's used a lot is going to be corticosteroids. Corticosteroids. These ones are very interesting. You give these for tons of reasons, but one of the things that you need to think about is that it decreases the thyroxine binding globulin. And so what that'll do is it'll actually increase the amount of circulating free T4 or levothyroxine that's being delivered to the tissues. If that's the case and I have too much free T4, what would I want to do? I'd want to reduce the dose. So in these situations, I'd want to reduce the dose. These are just important key little things that you guys should know when you're talking about treating someone and managing someone with hypothyroidism with levothyroxine. Let's finish up the last conversation here with myxedema coma. All right, so myxedema coma is a very serious complication from hypothyroidism. And what I want you guys to take away from this is what are the triggers, what are the primary clinical features, diagnosis, we already talked about it, and what's the emergent treatment that you guys should know. So what happens is the most common triggers for someone with myxedema coma is the same as actually, for the most part, the thyrotoxicosis, and that is infection. So some type of underlying infection, maybe it be sepsis, or they've had some type of surgery, whether that be a thyroidal surgery or non-thyroidal surgery, but that's a big trigger, as well as some type of trauma. And there can be other reasons. Another common reason could be extreme cold temperatures. So extreme cold. So here, we'll throw that one out there. Extreme cold temperatures. Okay, you're out there shoveling snow for, I don't know, too long. Either way, any of these triggers, what they do is they increase your sympathetic nervous system drive. That's what they want to do. But remember what happens when you have low thyroid hormone? What does it do to your sympathetic system? It decreases the sympathetic system activity. So what happens is these things want to increase your sympathetic drive, but your thyroid hormone is saying, I'm going to decrease the sympathetic drive. So now what happens? The sympathetic drive that you would usually have to deal with these significant stressors is diminished. It's gone. And because of that, the hypothyroid effects are even more pronounced than usual. What do I mean? Remember the heart? This is the big one. What did it do? What would that sympathetic effect on the heart particularly, what was it doing? We were generally increasing beta-1 adrenergic receptor sensitivity. If I super shut down the sympathetic drive, what's going to happen? I'm going to shut down my heart rate really, really bad, right? And this is going to lead to severe bradycardia. I also can really affect the pumping function of the heart. And what happens is, remember we said that there was a mild decrease in contractility due to a decreased beta adrenergic sensitivity? If we have really, really high, low levels of thyroid hormone, that contractility drops a lot. And that contractility can eventually lead to a decreased cardiac output. What happens with the decreased cardiac output? Decreased blood pressure. And so these patients may also go into shock. So remember, bradycardia, shock, or hypotension. The other thing is, it decreases the sympathetic activity within the central nervous system. And that's a problematic issue as well, because that can lead to altered mental status. That can lead to confusion. That can lead to significant lethargy. And eventually, worst case scenario, a coma. Okay? The last thing I need you to remember is, remember how our normal thyroid hormone jacks up our metabolic activity? Well, if we really shut down that sympathetic drive and we really shut down the hypothyroidism issues, we really have a really, really low thyroid hormone and a really low sympathetic drive, that's going to significantly drop the metabolic activity, more than usual. To the problem where cellular respiration is occurring so little that so little heat is being produced. And if so little heat is being produced by our cells, what does that lead to with our body temperature? That's going to lead to severe hypothermia. And that can be super problematic, right? So what are the cardinal features as seen with this? Bradycardia, hypotension or shock, confusion progressing to coma, a significant hypothermia, and with these underlying triggers, okay? Once you've gone through the same diagnostic steps as you would with someone who has hypothyroidism in general without this complication, and you come to the diagnosis, you're going to start treating them empirically. And you're going to do this with IV substances. The first one that you're going to give is you want to give a bunch of T4, so the levothyroxine, and you also give another drug called the T3 leothyronine, just so that you have an amplified effect of both of them in this severe hypothyroid state. The other thing that you're going to want to do is put a lot of fluids in them, because they could be hypotensive and their heart rate may be low, and we just need to make sure that we maintain a good blood volume in them as well. And also, fluids are also important when it comes to people with hyponatremia. We may want to give a little bit more salt in the fluids. Again, not getting too crazy here though. The next thing that we want to give is, sometimes severe hypothyroidism like myxedema coma can mimic someone with a concomitant adrenal insufficiency. And sometimes it's really hard to rule that out. And so what we do is we treat them initially the same way as we would treat adrenal insufficiency until we've completely concluded that it's not there. So what do we give for adrenal insufficiency? We give IV hydrocortisone. Until we rule out adrenal failure. And then after we've ruled out adrenal failure, you can decrease the IV hydrocortisone or discontinue it. But again, most important thing is IV T4, T3, fluids, IV hydrocortisone until you rule out adrenal crisis or insufficiency. That is the treatment of myxedema coma, and that finishes our discussion on hypothyroidism. What's up, Ninja Nerds? In this video today, we talk about hypothyroidism. I hope that you guys enjoyed it, and I hope it made sense. All right, Ninja Nerds, thank you, and as always, until next time.